Hi, it's Justin Shore from Chronicles of EMS with your 60-second life-saving tip of the day. Today we're going to talk about what to do after you called 911. Well, congratulations on your life-threatening emergency. I'll be there in just a few moments in the ambulance, but before I arrive, I'm going to need your help. Number one, I need to find your house. Make sure your house is numbered and I can see it from the street. 4-inch tall letters should do. And make sure they contrast. Don't put white numbers on a white house or black numbers on a black house. If you can, get a light above it so I can see it at night. Secondly, turn on your porch light so I can see exactly where I'm going. While you're there, unlock the front door or even crack it open a little bit. That'll help us get in safely and securely and help you and your loved ones. Until next time, this is Justin with your 60-second life-saving tip.
We have to remember that emergency medical services in the United States is very young. Okay, it's 40 years young. But also, too, I don't want that to be the calling card or the sound for an excuse of why we're not advancing. Well, we're only 40 years old, where nursing is forever. It's a million years old, and so forth, and so is the fire service. With the technology and the ability, such as and the access to social media and other educational tools, there is no reason why EMS and paramedicine can further proliferate and actually become that educational standard that we want. There are degrees now, although they're on a limited scale. Okay, and I believe that we need to get to the point, to get to that place where Mike's talking about and what you're discussing of where in America paramedics will be allowed to make that decision tree. They need to build up the resume. They need to build up the educational standards at that point to where the community and the physicians and so forth will have that level of trust in the education they receive, such as an associate's degree is mandatory with options for bachelor's. They've even started to discuss master's degrees that paramedics would be well advised to go ahead and pursue. But there's really nothing set out there. Everything now that paramedics should get thrown into to pursue has to do with Homeland Security. That's the biggest thing. It's like, oh, okay, well, you're a paramedic, you know what you should do? You should go ahead and get a degree in Homeland Security. And that's what I have. I have my master's degree in Homeland Security, Emergency and Disasters Management. But it's really, the focus is handling disasters and Homeland Security. And EMS is a very small component. Yeah. So what we need to have is a standard that allows us to go ahead and obtain that educational respectability to be able to begin to make those decisions on the line and so forth.
To the point you make, one of the concerns that we kind of always frame our thinking around in EMS is worst case scenario.
Yeah.
And I've seen enough examples in my career of things that seem innocuous. I had a crew when I worked in Denver got caught in a bar fight, and they walk in and there's a guy busted up against a jukebox. Jukebox is kind of shattered behind him. He's sitting there, his jaw's dislocated, a couple of teeth on his shirt, bleeding. And as the crew is walking down, this guy's really drunk, nudges him and goes, "Hey, doc, do I need stitches in this?" And he shows him a little scratch on the back of his hand, and the medic looks at it and says, "Go wash your hands, you'll be fine." And they go take care of the guy who's busted with the jaw, spinally immobilize him, take him onto the hospital. Well, a day and a half later, the guy who had bucked him and said, "Do I need stitches in this?" shows up at the emergency department at Denver General with an arm that's all swollen up, got a fever of 103. He ends up arresting in the waiting room because he was septic, and it was a fight bite. He was the guy who'd hit the guy up against the jukebox. And the medic was asked this question, "Does this need stitches, doc?" Well, there's nothing in the paramedic curriculum that teaches people how to assess. Does it need stitches? Does it need to be protected from infection? Those kinds of things. So there are, and my crews, they run them every day, all kinds of calls with people calling for, "My acne's been itching for 6 years and I just can't take it anymore," all of those kinds of things. And the challenge is that when you're deciding whether or not somebody needs to go to the emergency department or is okay to stay home or to go to see their doctor the next day, the reservoir of clinical information that you bounce things off of is not very deep. I teach in a master's degree program in emergency health services management. It's not a clinical program. The degree programs that are out there, people go to paramedic school and then they take a bunch of other classes, but they're not clinical classes.
Yeah.
So they're not building people's clinical capacity to make good decisions. And that's the thing that makes me nervous.
Even if we do build the educational standpoint up to pre-med, one of the things we're moving towards with EMS 2.0, this concept that we have is better education to build a better system that's better for the patient. One of the problems we have is you can give me all the training in the world. I can go to PA school. The problem is as soon as you put me in an ambulance with a Star of Life on my jacket, I still have to go to the emergency room to the triage nurse who has less training than I do, less education, who's still going to ask me the exact same questions. We still have, like you said, that funnel. Everybody still comes to that one point. That's our problem. What we need to be able to do is go out and, okay, you've got asthma. You've been having problems with your asthma. I've seen you before. You know what? We're not going to take you in the emergency room. We're going to pop over to the asthma clinic. I'm going to take you there. Why can't we do that? That's the next step that needs to come is I love what you guys are doing in that you have a need in your community. You're addressing it, and you're getting there. I mean, in 1 year, you've gone from I see a problem to we're going to research it. Until we can get those people diverted into where they need to go to get what they need, we're not getting anywhere.
And I think the way I would frame what you just said is that, it's a system of healthcare, and we are part of that system. And we've got a whole community of people who have needs, and the system isn't designed to meet the needs of people in this country right now. And you say, so where's the system that does? And maybe the UK system has got a lot of things I suspect that we could learn from in this country. One of the things Alameda County's been doing is there's a team that's part of the Ethnic Health Institute that has been actually traveling to Cuba about every 3 months for the last 2 years, studying their health system. They have better outcomes in 17 out of 36 indicators than we do in the United States, and they spend less than 10% per capita that we do on healthcare, and they cover everybody.
And speaking of spending and cost always comes into it, these folks that you give the community outreach to, are they billed for that?
No.
From the third service? No. That's just that's
This is-
built into the cost. And
the problem, and there are a number of problems with part of the system. Currently, the reimbursement for EMS services is either tax funds, bake sales, or patient charges. I mean, those are pretty much the sources. In our community, we don't do bake sales, so what we do is we send people bills, and the reimbursement system only pays us to give people rides. At this point,
they're just talking about that in the chat room right now. I see BMT, EMT Goose talking about, how one of them said you don't bill if you don't transport, and I guess that puts a big hurdle in the way of transport.
Think about this for other parts of healthcare. If you're my doctor and I come see you and I smell like tobacco smoke, and you say, "Hey, Mike, are you a smoker?" "Well, yeah." And you really ought to think about quitting smoking. Let me give you this 800 no buts number. Why don't you call it and let's set you up in a program. The doctor gets paid $18 by Medicare to have that conversation, because that conversation is clinically valuable. There's evidence that shows that people who have conversations about stopping smoking with their clinicians have a higher quit rate than people who have other interventions. If Bill takes care of me in the back of an ambulance and he smells tobacco smoke in me and he says, "Mike, you ought to quit smoking," it has the same clinical impact on my quit rate, but he can't charge for it. All it is a choice about what the reimbursement folks pay for. And part of the reason to do some of the research on this is really to build the case that we're clinical professionals, we're not just ride givers, and that the medicine that we practice that is similar to what's practiced by nurse practitioners, PAs, or physicians should be reimbursed in a similar way. But we have to prove our value in that in order for them to think about.
And I think that's a really interesting concept, because one of the issues that we're having at a national level and a federal level is that who is our representatives at Capitol Hill? Because what you're talking about is reimbursement and federal funding. Also, how many specific EMS grants are out there? That's the most significant issue that we're facing for emergency medical services in itself. So our representation at Capitol Hill in Washington, D.C., to basically the driving force that would fundamentally go ahead and unify and codify EMS nationally, we're represented by a $2 million agency organization that is in the Department of Transportation. That just doesn't work.
Yeah.
You know, and so the situation is, and actually this is one of the goals of the EMS Chiefs Association, is to try to go ahead and advocate for a larger EMS administration. You know, an agency that has a say, that has a seat at the big table with the president, that is up there, that can suddenly receive millions and millions of dollars in money and funding to be able to go ahead and distribute EMS specific grants to agencies to pay you for that, $18 for that, to go ahead and open up those social services and those aspects, you know, and tie them in together with the emergency rooms and the ERs to bridge that gap that we're all facing fundamentally, you know, and to break down the fiefdoms and how we've created our EMS system in piecemeal overall. We have these word fiefdoms of the counties each have their own kingdom. We need to unify everything together. Our system is not global, it's actually fractured, if you really think about it nationally. Just even within the state of California, my protocols are totally different from Los Angeles counties. It's just we're in the same state. So until we can get to that point to where we can show unity, just unity in our medicine, unity how we think, and unity in our action, you know, and with that we can get that support and begin to work together to create that large agency and advocate for that in DC, to bring those things down. That's kind of the larger scope picture that you're talking about, to get you that money and that funding to basically do your job better and provide better patient care.
Well, how can an EMT listening in Billings, Montana, tap into your organization to try to get more funds for their area?
You know, what I would advocate to do now is to go ahead and go online, and you can do a Google search for the International Association of EMS Chiefs, and our website will pop right up. And what you'll see, it's a newly formed organization. It's only about 2 years old now. And basically where it came from was it's an offshoot of the Chiefs Division from the National Association of EMTs. And so we went ahead and formed our own organization. And currently right now we have all the EMS chiefs from major cities and districts from New York all the way to San Francisco. And we have our annual summit, and we work together as much as possible to try to go ahead and support and advocate for EMS in our jurisdictions and EMS nationally and internationally.
I was going to say, do you have EMS chiefs from around the world as well, with it being the International Association?
Yes, we do have some memberships that are beginning to grow, and we're trying to get the message out there. And so, being a fledgling association as it is, it's like a small startup. We're just now beginning to get the momentum. We just had our first Chief Summit last year in Washington, D.C. It was fantastic. We had many representatives from Capitol Hill. Craig Fugate, director of FEMA, was our closing note speaker. It was fantastic. You know, it's a way for all of us to get together and basically speak about the issues and problems that we're having in our government agencies and our jurisdictions and so forth. And like this, come together and talk about them in a forum to try to find some solutions. Not just talk, but actually find solutions.
Yeah. So what are the 2 or 3 main things your organization is concerned about in EMS in the next 5 years?
In the next 5 years is basically funding and support. You know, is that we do need to begin to build that agency mindset at the federal level. We need a seat at that table to advocate for our paramedics, for the workers, for us in self, and to bring in those safeguards and to actually provide those grant opportunities so the services don't suffer. And also to expand our role within the medical community, like we've been discussing here, is to open us up, and rather than just being ambulance drivers or that bus that basically shows up with lights and sirens and throwing people into the back and having to mandatorily transport everybody to the hospital, to be able to make those clinical judgments out there in the field, to be able to streamline medical care and provide better medical services to our patients.
We need training, we need the technology, and we need the trust of the people in charge.
And we need the
patients.
rest of the system to shift and mold around us. Actually, there was another gentleman who was going to be with us today who runs the Healthcare Services Agency in Alameda County, and he's kind of best known for school-based health clinics. So he's put health clinics in high schools, junior high schools, and he's got a new concept about putting health clinics in fire stations. So you know, small clinic, nurse practitioner, maybe assisted by an EMT or a medic, maybe from the fire department, to be able to provide location-based
Community-based.
healthcare.
Yeah. It's exactly what you were speaking of with transporting to clinics and so forth, but it's also, what that handles is the walkable communities. It's a very out-of-the-box concept, and it's Alex Briscoe, who's the new Healthcare Services Aging Director for Alameda County Public Health Department. An unbelievable, just a brilliant man. And conceptually, fire stations are strategically placed, as you know, within the communities that they serve for access and rapid response within that district. What better place to place a clinic right next to the fire station, because that's accessible, it's open, and it's there.
And building it into it, because you have a fire service that is predominantly an EMS service that occasionally goes to fires. You have these highly trained, very motivated people doing very little. And even in some of the busiest places, you know, I'm sure you can't get DC Engine 10 to sit down and bring people in for a dental exam where they are. They're just too busy. But if we can decrease their call volume by getting people to proper locations.
Well, but if they had a nurse practitioner there who didn't go on calls with them, who could see some of those people who could walk
Or
up to
Does
the
it
station.
need to be a nurse practitioner?
practitioner
What's going to be the primary role? Is it going to be health screening or?
Well,
treatment?
a lot of it is chronic disease management and prevention kinds of things. So people with diabetes, asthma, epilepsy, congestive heart failure, sickle cell anemia,
That couldn't be a specially trained paramedic?
It could be. But right now, in order to set up a clinic and get the financial aspects of a clinic,
The funding.
the reimbursement strategy is aligned with people who have got the clinical credentials to be able to get reimbursed for that kind of work.
Yeah.
We were looking at the University of New Mexico back in 2000. We have a project where we were trying to do that kind of thing, put a clinic in a firehouse. We realized that wouldn't work. You have to put the firehouse in the clinic. And what we did was, these large clinics in some of the suburban areas, they're kind of urgent and non-urgent. You've got kind of two sides to the building. And why not on the urgent side put your ambulance bay? And when your crew's not on a run, they can help out in the clinic. Or if they go on a run where it's, do I need stitches? I don't know, let's go find out. Instead of going to the emergency room, we're back to the clinic.
In the between 1974 and 1980, I worked in a place like that. It was halfway between Denver and Colorado Springs. Castle Rock, Colorado, there was a freestanding emergency department clinic. Our ambulance crew was based out of there, and that's where I got to learn about other aspects of medicine.
Yep.
Because I was trained to run the X-ray machine. I did all the pregnancy tests and all the monospots, and I can still do a white blood count on a slide, with a little calculator thing.
Yeah.
You learn to do that kind of stuff just because you're helping out. In our case, it was a nurse practitioner who was doing all the other primary care, and at that point in time back then, we could transport to that clinic if it was a patient that didn't need to go all the way into town.